Welcome to AETCM, the emergency medicine channel. 10-year-old boy, incompletely immunized as per schedule, presented to ER with complaints of fever, sore throat, breathing difficulty of 1 day duration. Initial 10-second assessment. Since the patient is 10-year-old, pediatric assessments called PAT triangle was assessed. With the appearance, patient is anxious, restless, with toxic looking, with drooling of saliva. Patient is in a sniffing position. Patient was leaning forward, sitting and leaning forward.
What is that position called?
Tripod position or stiffing position. Then breathing.
Sniffing position is not leaning forward. It is sniffing position is this. Tripod position is leaning forward position.
Hyperextension of the neck. Then breathing wise, stridor present with marked retractions, tachypneic and labored breathing present. Circulation wise, circulation was normal with no pallor or cyanosis. Then airway is drooling of saliva present with audible stridor with muffled sound. Patient is not able to complete full sentence. There is no hoarseness of voice. Breathing wise, respiratory rate of 36 per minute, tachypnea with marked chest retraction present, bilateral air entry present with saturation of 95%. Circulation, pulse rate of 128 per minute with BP of 120/60. S1 S2 heard with all peripheral pulse palpable. Disability GCS is 15/15. Patient is in a tripod position with a GRBS of 100 per DL. Exposure temperature was 101 degree Fahrenheit. Since the patient is febrile, we will keep the patient in a calm environment without disturbing his homeostasis. Then we give an injection PCM 1 gram along with tepid sponging. Then sample history, a 10-year-old boy who was not completely immunized as per parents, presented to ER with complaints of 1 day history of high grade fever, which was 102 at home, associated with sore throat and odonophagia. Within hours, patient developed muffled voice along with drooling of saliva. Inspiratory stridor was also heard, which worsened in the evening. Parents also noticed that child preferred to sit leaning forward with mouth open and neck extended along with drooling. There is no cough or nasal congestion or URT, like rhinitis symptoms, foreign body aspiration, history of similar episode in the past. There is no headache, vomiting, abdominal pain or loose stools. On examination, patient was toxic looking, anxious, restless, patient was sitting, leaning forward with neck extended position, that is tripod and sniffing position. Along with systemic examination wise, respiratory system inspection is intercostal and suprasternal retractions were there, with the trachea was in midline. Percussion resonant sound in both sides with auscultation. Inspiratory stridor was present.
So we have a patient who is a 10-year-old boy who has come with fever, sore throat, and there is stridor. Patient is sitting in a tripod position and also a sniffing position. So what are the differentials that comes to your mind when a child more than 6 months present to you with acute onset stridor? What are the differential diagnoses?
Most common cause is croup
or laryngobronchitis. Other than croup,
bacterial tracheitis, epiglottitis, retrograde
pharyngeal abscess, parapharyngeal abscess, foreign body aspiration, anaphylaxis. What about the cause of stridor in a child less than 6 months?
Mostly congenital abnormality like laryngomalacia, then
laryngeal web, vocal cord paralysis, subglottic stenosis. These and all are causes of stridor. So this child is a toxic, sick-looking child, and the onset is very acute. Only 1 day history. So what do you think the child is having?
Since it's an acute onset, toxic looking with fever, sore throat with odonophagia, we initial provisional diagnosis of acute epiglottitis is made.
Okay. What causes acute epiglottitis?
Acute epiglottitis is mostly caused by, it could be infectious or non-infectious. Infectious causes, most common cause was Haemophilus influenza B. But since after immunization schedule, HIV
The rate has come down.
Rate reduced. So in post-vaccine era, most common cause is Streptococcus or Staphylococcus.
Beta hemolytic streptococcus, Staph aureus, etc. can
In
cause.
immunocompromised, Candida species can also.
Candida. And non-infectious causes?
Causes include thermal injury, caustic burns, or direct trauma to trachea.
Okay.
Causing
So these are the causes of epiglottitis. Okay. And how does a child of epiglottitis present to you? What are the signs and symptoms, and what is the feature that differentiate an acute epiglottitis from a laryngotracheobronchitis?
So mostly patient presented with fever and stridor with marked retraction, tachypnea and labored breathing.
This will be there in the other one also.
Yeah, but hoarseness of voice is more common with group.
Hoarseness will be there in both. There is one feature which is
Muffled.
less common. No, muffled hot potato voice is the classic feature of acute epiglottitis. Whereas in croup, the patient will have a barking cough. The epiglottitis, the patient might not have cough. If in case patient has cough, it will be a very mild cough, not the typical barking type of cough which you see in croup. Okay, so what are the features of epiglottitis?
So abrupt onset of fever with sore throat, stridor, and drooling of saliva, which rapidly progresses to inability to swallow oral fluids, followed
So
by
is it
stridor
an
and respiratory
emergency?
distress. Yes,
Epiglottitis is an emergency. Why? Because it can cause
complete
complete obstruction of airway, that too in a very fast onset. So we have to secure the airway before the disease progress, and that is very quick. So we have that. Therefore, when a child comes to ER with features suggestive of epiglottitis, first thing to do is take the triage the child into the red area, the resuscitation area. Okay, and then
we have to
why the child presents with drooling? What is drooling? Because he can't swallow. It is very painful. So the saliva and all, it causes drooling of saliva. In adult, they will present with dysphagia, dyspnea, drooling. Whereas in children, they normally present as a toxic looking child with a very sore throat and child leaning forward. Why the child lean forward?
To make the
airway, so that the air, because in epiglottitis both the epiglottis and the subglottic space undergoes inflammation and it becomes edematous and it will obstruct the airway. So leaning forward position and sniffing the morning air position will cause some relief of the airway obstruction that is happening. Okay.
So immediately we have to, as you said, immediately we have to triage the patient to the red area and get emergency assistance from the airway specialist like anesthesia, or we have to inform an ENT specialist.
They have to be informed prior.
Right. Then we have to prepare the airway manuals, and we should not try to visualize the vocal cord prior because any disturbance can cause complete occlusion of the airway. So in young child we are not even do not perform invasive cannulation if the patient's hemostasis is disturbed.
So what is the first thing to do in a child? You have triaged the patient into a red area. In the resuscitation area, what is the first thing to do?
Make the patient sit upright in
a child who is already sick looking, very agitated, will a child sit like that? No, child won't sit. You have to make the child sit in the position of his or her comfort. So if you want, you can ask the mother to hold the baby also, because the child has to be in his comfort position, need not be in sitting, leaning forward position and all. And next thing, should we give oxygen? Should we give supplemental oxygen?
100% humidified oxygen
It can be given if the patient is hypoxic, that too not in a way that it causes distress to the child. Basically, you have to keep the child in his position or his or her position of comfort. Okay. After that,
then if there is a sudden deterioration with complete airway obstruction, attempt of bag and mask can be done. Like
what is the drug that has to be given immediately?
Nebulization of adrenaline.
Adrenaline has to be given. How do you give nebulization?
L-adrenaline can be
L-epinephrine has to be given 1:1000 dilution at 0.5 ml per kg has to be given, maximum 5 ml. It has to be given. What does it do? It will reduce the edema. Okay, do you give steroids?
Steroids can also be used.
Yeah, it can also help to reduce the edema. So dexamethasone and all can be given. Okay. And now primary aim is to secure the airway. So what do you do to secure the airway?
So if the patient is unable to oxygenate, that is pulse oximetry.
If you have given adrenaline and you have given steroids, the child has become symptomatically a bit better. What will you do? You will go for airway securing, or will you wait?
We will electively we can secure.
Yeah, we have to do that because it can again progress in a very fast rate. So as soon as possible, we have to secure the airway. What do we do to secure the airway?
In an unstable patient, we can use a radiolaryngoscopic RSA, rapid sequence intubation can be done.
Nasotracheal intubation and all can be attempted.
If it is not able to do, we can do a needle cricotomy or a thyroid.
In a child of 10 years, do you do cricothyrotomy? You can do. More than 9 years, you can do. In less than 9 years, you will do a needle cric. Why? Because the cricothyroid membrane is not properly formed in a child. So you can't put a cricothyrotomy. Instead, you can do a needle cricothyrotomy. Okay, so that can be done as an airway manner. What are the investigations or what are the supportive? If for this patient, since it is an acute emergency, you don't go for doing all the investigations. But for the sake of information, what are the investigations that can be done?
Basic blood works can be done with the CBC CRP with the CBC and CRP, where we'll mostly see elevated total counts with the CRP elevation. Along with the ABG can be taken, which will show mostly hypoxemia. X-ray neck can be done, which is not that emergency.
What neck? X-ray? Lateral neck.
Soft tissue neck, which may show a thumb sign.
What is thumb sign?
That enlarged epiglottis is seen as a thumb.
Enlarged epiglottis from the anterior wall of hypopharynx can be seen as in the form of a thumb. That can be seen. It is suggestive of, it has a very high sensitivity and specificity to suggestive of epiglottitis. What is the gold standard investigation? Laryngoscopy, where you properly visualize the edematous and the inflamed epiglottis. Okay, and the rest are supportive investigations like blood works can be sent, etc. And is there anything else to be added in the treatment part?
Antibiotics should be added.
What antibiotic do you prefer?
Bot-spect antibiotic, mostly third generation cephalosporins can be added along with MRSA coverage if we are suspecting
vancomycin, etc. has to be added.
Mostly ceftriaxone 50 to 75 mg per kg per day IV or cefotaxime 5 mg per kg every 8 hourly. If MRSA is suspected, we can also add vancomycin. Dexa can be also given to reduce 0.6 mg per kg along with tapering in 48 to 72 hours. IV fluids, since patient is NPO, we can start on IV fluids and nebulization of adrenaline if airway is compromised. But the main theme is we have to secure the airway till the stridor is reduced. We'll secure the airway, we'll keep him, we will
give the supportive measures.
After 2 days, when the stridor will subside, we can extubate the patient and look for other.
So that is basically of acute epiglottitis. A child will present to you in a very toxic state, and with all these features that suggest to you that the patient is in acute epiglottitis. Immediate management is airway, and after airway securing, you have to give adrenaline and antibiotics and other supportive measures. Main thing is to differentiate between acute epiglottitis and other causes of upper airway obstruction in a child.